Okay, so I'm just going to talk about overall management of cardiac dysfunction in ARDS. It's an interesting topic, and I'm going to boil it down to a few different areas. So in ARDS, we've got pre-existing cardiac dysfunction. Prior to contracting ARDS, we have pulmonary hypertension and right ventricular failure and left ventricular dysfunction, which may be related to sepsis-induced ARDS or as a consequence of multi-organ failure secondary to ARDS. Also issues with hypovolemia, pneumopericardium, or other causes, which I've got a nice picture of there. So we did include in the new definition, we did include some, actually is there a pointer? This one? Yeah. We did include some areas of pre-existing cardiac disease in ARDS. Previously, they'd been excluded from the definition of ARDS. So standard cyanotic heart disease and left ventricular dysfunction. So of course, you can still get ARDS with these underlying pre-existing conditions. And this is just an example. This is a baby with a cardiomyopathy, dilated cardiomyopathy, came in, developed worsening respiratory failure, was intubated. This is the X-ray 2 days later. Severe hypoxia, and patient developed NPA, came back for RSV positive. So this is a patient, obviously, that had left ventricular dysfunction and then developed ARDS. This is a patient with a BT shunt with pulmonary atresia, came back after a stent to one of the pulmonary arteries, which was narrow. 2 days later, developed bilateral changes on X-ray, worsening hypoxia, and again, rhinovirus was isolated. So this is another example of a patient with underlying cardiac dysfunction and ARDS. I just might start off with a case. This is a 6-week-old boy presented with a 1-week history of cough, tachypnea. Rapid ward test was positive for RSV. Was transferred, represented 2 days later with severe respiratory distress, and was transferred down on high flow to our institution from a regional centre. And on arrival in ED, had severe distress, was gasping, and had a severely depressed conscious state. And this is the X-ray. So you can see there's just a bit of a lifting of the apex and a bit of a prominence around the pulmonary artery there. Patient was intubated mainly because of the severe distress and conscious state. Gave him a fluid bolus, transferred to PICU. And then was stabilized initially, but then deteriorated pretty rapidly. So developed a respiratory acidosis, or combined respiratory and metabolic acidosis. CVS was unstable, was started on inotropes, and was noted to have this very high white cell count with a neutrophil count of 72, so a high neutrophil to ANC to white count ratio, and a high CRP. In the X-ray, you can see there's deterioration with bilateral changes. Patients intubated now with bilateral changes there. And so we put an echo probe on, and you can see this is an apical view, so left ventricle, left atrium, right atrium. You can see a massively dilated RV with extremely poor function. And you can see how the left ventricle is completely squashed here, so the filling of the left ventricle is going to be impaired. And this is just on a short axis view, so this is again looking at the right ventricle and the left ventricle, and that left ventricle is almost completely collapsed. And this patient obviously had severe pulmonary hypertension on echo. We tried to maximize with HFO, improve the pH, and commenced inotropes, managed the hypoleukocytosis, came back with pertussis isolated on day 1, so the RSV was obviously furphy. Baby further deteriorated on maximum support, was considered for ECMO, but we declined based on the poor outcome with pertussis pneumonia. I won't talk about malignant pertussis because Anusha's going to talk about that this afternoon. But how common is pulmonary hypertension in ARDS? So these are adult studies, just looking at patients that have had right heart catheterization with ARDS, and both showing a very high incidence of high pulmonary artery pressure, up to sort of 90% having pulmonary hypertension. And the pulmonary hypertension was associated with mortality. So you can see here, as the pulmonary pressures increased, These are the non-survivors. You can see they separated out based on the pulmonary hypertension. So pulmonary hypertension is common in adult ARDS and associated with poor outcome. In pediatrics, the picture's not so clear, and we don't have right heart catheterization, but these are two studies. One, this is a retrospective analysis of 100 children and a prospective study. All these patients had echocardiography on day 1 with acute respiratory failure and showed a very high incidence of pulmonary hypertension, and that pulmonary hypertension was associated with mortality in those patients. And what's the pathophysiology of pulmonary hypertension in ARDS? Well, you've got hypoxic pulmonary vasoconstriction, which of course is a normal adjustment of the body to try and maintain oxygenation. You've got inflammatory mediated vasoconstriction, microvessel thrombi. So this is a pulmonary artery here, and you can see it's just completely chock-filled with thrombus, and that's another big cause of pulmonary hypertension in ARDS. You've got extravascular compression and endothelial injury and edema. So many causes of pulmonary hypertension. Of course, pulmonary hypertension then leads to right ventricular dysfunction. We know that right ventricular dysfunction is pretty common in adult ARDS, about 10 to 40%. In pediatrics, less clear, but RV strain is associated with mortality and is seen in about 35 to 40% of patients of children with ARDS in a small study. So there's some specific etiologies which can result in pulmonary hypertension in ARDS. So I've just talked about a case of pertussis. We've got other causes here which I'll go through. The definition is a pulmonary artery pressure of greater than 25, which in pediatrics where we're diagnosing by echocardiography a tricuspid regurgitant gradient of a greater than 20. So what about RSV? So this is a nice study just looking at around 30 patients who were intubated with RSV, and shown that about 10 out of 30 patients had mild to moderate pulmonary hypertension on echocardiography on day 1 post-intubation. And this is a case we had in our unit recently, a little 4-month-old with trisomy 21 who actually had an ASD as well, presented with RSV pneumonia, again, widespread changes, hyperinflation, very small heart. And again, this patient, we put the echo probe on, again, very dilated right ventricle with poor function. You can see it's just rocking there, and there's the ASD there. And we've got bidirectional shunting across the ASD, so blue and red direction of Doppler flow. So that just indicates there's very high pressures on the right side of the heart. This baby, and there again, dilated RV and compression of the left ventricle. So you've got impaired filling. What we did with this baby, we put the baby on nitric oxide, continued supportive therapy, and kept trying to start sildenafil because of these raised pulmonary pressures. Of course, the problem with sildenafil can cause an increase in intrapulmonary shunt. So we kept trying to start it. Eventually, we managed to get the baby on sildenafil with adequate oxygenation, and were able to wean the baby, but it did take about 2 weeks or so. What about BPD, prematurity in BPD? Well, the incidence of pulmonary hypertension in BPD is about 25 to 30%. I didn't realize this, but the mortality in the first 2 years of babies with severe BPD is about 50%. And BPD is an underlying etiology in pediatric ARDS in about 10 to 15% of cases. And this is a baby, I think he's about 7 months old, X23 weeker, with, you can see he's got a dilated heart there. He presented with RSV, pneumonia, which you can see dense changes here. We managed this baby on humidified high-flow oxygen. And this is his echo. So again, dilated right ventricle with significant tricuspid regurgitant gradient there. And when we measure the velocity of that gradient, the maximum gradient 64. So you add that to the CVP to give you the right ventricular pressures. So you can see the right ventricular pressures are almost systemic in this baby. And this baby is interesting. He was already on sildenafil. We managed him with humidified high flow with nitric oxide. And we ended up starting this baby on bosentan. And it actually worked, believe it or not. So baby recovered pretty well and has gone back home with severe BPD, so let's hope he doesn't get any more infections. Let's skip this one. It's just a baby with an older child with congenital heart disease, again just showing pulmonary hypertension, RV dysfunction. And you can see here, this is a long axis view. So you've got your right ventricle here, which is dilated, your left ventricle and left ventricular outflow tract. And just see how thick and small cavity that left ventricle is. So it's just getting squashed, it can't fill, and the cardiac output's always going to be severely impaired. And again, okay. So what's the therapy of pulmonary hypertension? Well, firstly, you've got your basic measures, which I won't really talk about. In ARDS, the role of ventilation and PEEP is interesting because your filling is impaired, particularly left ventricular filling. A further augmentation of intrathoracic pressure with PEEP, high mean airway pressures, is going to further impair your filling. So it does make the management quite difficult in a lot of cases. You've got vasodilators which are non-selective, such as milrinone and levosimendan, but all these drugs potentially increase VQ mismatch and intrapulmonary shunt. And you've got selective or targeted therapies, so inhaled nitric oxide, sildenafil, and bosentan. The management of RV function is really self-explanatory, but trying to reduce RV afterload, trying to improve RV function with inotropes, and then rescue therapy with ECMO if that's available. The pH, PaCO2, and PO2 obviously are very difficult to manipulate in severe ARDS, and you've got competing priorities. You don't want to, if you're trying to maximize your pH or your oxygenation, then you're going to run the risk of ventilator-induced lung injury. So you always have competing priorities there. There may be a role of hyperventilation or a role of HFO in improving pH in some cases. Hyperventilation does reduce PVR, but in Des Bone's study, we're looking at the first comparison of hyperventilation and nitric oxide. It also reduces cardiac index and increases SVR. And hyperoxia, well, your hands are tied in a lot of ways with severe ARDS in managing that. Just to note, really, all the systemic vasodilators potentially increase intrapulmonary shunt in patients with lung disease and impair oxygenation. And all these drugs as well, which may reduce PVR, which we might use for other reasons. So inotropes, dobutamine, milrinone, levosimendan, anesthetic agents, narcotics, propofol, can all impair hypoxic pulmonary vasoconstriction, all increase intrapulmonary shunt, and all contribute to hypoxia in babies with severe lung disease. Just on inhaled nitric oxide, we know that it probably improves oxygenation in the acute stage, but no effect on mortality in this meta-analysis. The dosing, probably at low doses is effective. At high doses, you run into problems with methemoglobinemia, but it has a pretty good safety profile overall. Sildenafil, again, we used it in a couple of these babies, but you do run the risk of intrapulmonary shunt because it impairs hypoxic pulmonary vasoconstriction. And this graph here just shows the effect of intrapulmonary shunt after a dose of sildenafil, so it increases to 30%, and that's going to run the risk of causing exacerbating hypoxia. And again, bosentan is probably at risk of having similar effects, but there probably is a role for that in children with pre-existing lung disease or BPD. And we have used that in a few babies in that category, and it has been beneficial. I just wanted to talk briefly about left ventricular failure associated with ARDS. The incidence of multi-organ failure in severe ARDS is very high, and LV dysfunction is seen in about 60% of cases of severe ARDS. It has a strong association with mortality, and left ventricular failure may be pre-existing, as showed in those earlier slides, may be associated with ARDS, in sepsis-related ARDS, or it may be a complication of ARDS. And I'll just go through a couple of cases here. This is a case, baby with strep pneumonia, who required intubation, had quite severe air leak. It's got 2 drains there, but developed quite cystic lung disease. And again, this is the sort of picture you get on echo with these type of patients with severe ARDS. So this is a long axis view, left atrium, left ventricle, left ventricular outflow tract. And you can see the left ventricle is dilated, and there's sort of mild to moderate reduction in function. And that's a typical picture that you get with severe ARDS. This baby developed more severe air leak and went on to VV ECMO with an Avalon catheter here. I've just got a nice view of that here. So there's the tip of the catheter in the IVC, SVC, and there's the outflow tract just jetting oxygenated blood across the tricuspid valve into the right ventricle. And this is an interesting case because this little girl was on a lot of inotropes prior to going on to ECMO. I mean, partly that was a high mean airway pressures, HFO, and air leak that she was requiring. And it just showed that as soon as we got her onto VV ECMO, improved the oxygenation, reduced that intrathoracic pressure, the inotrope requirements resolved, and we got away with managing her on VV ECMO rather than VA ECMO. This is another typical case, immunosuppressed patient, post-chemotherapy, developed sepsis with ARDS. And again, this is a sort of typical, this is an apical echo, apical view, left ventricle and right ventricle. Windows aren't very good because of the severe lung disease, but just look at that left ventricle. So it's dilated, severely tachycardic, and very poor function. And that's a typical picture that we get. This patient was on, I think, 1.5 mics per kilo per minute of adrenaline and noradrenaline. I've never seen anyone survive on those numbers, but actually did really well. And there's just a long axis view here, just showing that dilated, poorly functioning ventricle. So the management of LV failure is really to try and enhance LV filling. You've got your mean airway pressure manipulation, so using high mean airway pressures does make filling difficult. So you need to balance that. The effective fluids might be beneficial, but as you can see, when you've got a dilated ventricle like that, the effective fluids could be pretty negative. Inotropes, of course, and then there's definitely a role for ECMO in these patients. We've had expanded use in pediatric respiratory failure of ECMO, consistent survival of about 57% overall, despite an increasingly complex group of patients being put onto ECMO with respiratory failure. There's been increasing use of VV ECMO in pediatric ARDS over the last decade or so, and the survival in VV ECMO is about 66 to 70% based on the ELSO registry compared to about 50% with VA ECMO. So improved survival, maybe due to underlying causes, of course. What's interesting is the rate of conversion from VV ECMO to VA ECMO is only about 6% of cases, and the survival in those cases is around 50%, so not much different than the patients that go on to VA ECMO for pediatric respiratory failure. So I think there's definitely a role there for increasing use of VV ECMO, despite patients needing high vasopressors or inotropes before. And you can see this study just showed the outcome of VV ECMO is good despite high vasopressor requirements pre-ECMO. So in conclusion, cardiac dysfunction is commonly associated with pediatric ARDS, maybe pre-existing, and maybe a complication of ARDS, and cardiac disease definitely impacts on outcome in ARDS. And the management of cardiac dysfunction, as I've discussed here, it needs to be targeted. The effects on oxygenation need to be considered, and rescue therapy with ECMO is indicated in most cases. Thank you.